video. So starting with the name here, a mole. The medical term is a nevus or a nevus, and the description is a growth on the skin. Now it's cancerous if it's uneven or irregularly shaped. The next is a macule, which the medical term is also macule. So the description is a flat, discolored area on the skin less than 1 centimeter wide. And a great example is freckles or even tattoos. Now the next key term is boils or even pimple. This is known as a papule, which is a red raised area of skin tissue about 1 centimeter. So acne, warts, and even insect bites would be classified as a papule. Next is a lump or bump described as a nodule. It's a lump underneath the skin that's at least 1 centimeter in size. And a great example is a granuloma with rheumatoid arthritis. Next is the tumor. Now the medical term is a neoplasm. So it's a mass formed when normal cells begin to change and grow uncontrollably. So benign is non-cancerous and malignant is cancerous. Great examples are BPH or even brain tumors. Okay, the next one is pretty simple here. A plaque, also called in medical terminology, just plaque. Now it's described as fast growth of skin cells that appear in a few small spots, looking similar to dandruff. And a great example is psoriasis and even eczema. Next we have hives and wheals. This is known as urticaria. Now it's not exactly the same, but it typically happens within the same reaction to an allergen. We see superficial skin coloring or pale skin swelling, usually surrounded by erythema, that red skin, that lasts anywhere between a few minutes to a few hours. And a great example is heat hives. Now lastly, we have blisters. The medical term is a vesicle, which we all know what a blister looks like. It's a small fluid-filled blister on the skin. And a great example is from burn patients. All right, that wraps it up. Thank you so much for watching. Don't forget to take your... Our next topic is burns. Burns are injuries caused by direct tissue damage from exposure to either the sun, chemicals, thermal, like boiling liquids, and even electricity. Now, as you know, the skin is made of 3 layers: the epidermis, the dermis, and the subcutaneous tissue, that fatty, bubbly-looking tissue. Now, after the layers of skin, we find fascia, muscle, and then bone. So in first-degree or superficial burns, we have damage to the epidermis, the top layer. So we see dry with blanchable redness, meaning that when you press on the wound, the redness goes away. Now, second-degree burns, called partial thickness burns, we have both the epidermis and dermis that are damaged. So the key sign to know is painful blisters, huge NCLEX tip. So write down these keywords here: red, moist, and shiny fluid-filled vesicles, or basically blisters that often leak fluid. So just think 2 layers of skin for 2-degree burns, or second-degree burns. Now, third-degree burns are full-thickness burns. We have 3 layers of skin destruction: the epidermis, the dermis, and possible subcutaneous tissue, described as key terms: dry, waxy white, leathery, or even charred black color that is non-blanchable skin. Big key terms for exams. Now, 4th degree, also a full thickness burn. These are the worst burns by far, as they go through all the layers of skin down to the muscles and even the bones. A unique sign is the lack of pain, since the destruction of nerve endings from all the burn charred areas. Even though they may look similar to 3rd-degree burns, these are far worse since they're far deeper. Now, for minor burns, like the 1st and 2nd-degree burns, these do not typically need hospitalization and can be treated outpatient with wound care and dressing changes. Whereas major burns like 3rd-degree and 4th-degree, these are deadly medical emergencies, requiring intensive care, which we'll cover in a moment. So first, care for minor burns. Say a client is cooking and then burns themselves, or say they spill a boiling pot of water on an extremity. So we always teach the 3 C's for pre-hospital care: cool water, cover the area, and clothing removal. So for pre-hospital care, C for cool water, key terms, is briefly soak the area. And no ice, no creams, and definitely no antibiotic ointment to open skin. The key term there is open skin. So this can lead to additional damage, and the creams, lotions, and antibiotics may interfere with the assessment from the healthcare provider. Now the second C is cover the area with key term, clean, dry cloth. So write that down. This is done to prevent infection and more damage in the pre-hospital setting. And the last C is clothing and jewelry removal near the burn, if not adhering to the burned skin. Only the HCP should remove anything adhering to the burned skin. So please be sure to write that down. Now Saunders mentions, the nurse instructs firefighters that in the event of a tar burn, which is the immediate action? Cooling the injury with water. Yes, that was our first C there. And the second question, for a chemical burn injury, the nurse instructs the employees that which is the first consideration in immediate care? Removing all clothing, gloves, and shoes, and any undergarments. Just strip down like you're going skinny dipping. Now for Kaplan, they mention discharge teaching to a client with partial thickness burns, or second degree burns, on the hand. We wrap the fingers with individual dressings. This is done to prevent tissues from sticking together and causing further damage. Now for the big mama, the pathophysiology for major burns. These can cause massive tissue damage and cellular destruction, resulting in widespread systemic inflammation that increases vascular permeability or capillary permeability. Just really fancy words for leaky blood vessels that fill up the body like a water balloon. So fluid, electrolytes, proteins, and other contents just spill over into the interstitial spaces, or the third spaces. Clients end up with severely low fluid volume intravascularly within the blood vessels, as fluid and electrolytes escape and now go into the tissues, eventually progressing into deadly hypovolemic shock. That severely low blood pressure that eventually causes death. This is why the number one intervention for major burns in the first 24 hours, and big NCLEX tip, so write down these key terms: IV lactated ringers, or LR solution, and IV normal saline, that 0.9% sodium chloride. These two will help save lives. They are isotonic fluids, which we call isoperfect fluids, since they stay inside the veins longer than any other solution, as it closely resembles the chemical composition of human blood. Fancy words for it increases the fluid volume inside the blood vessels, increasing the blood pressure and saving your patient's life. So don't let the NCLEX trick you here. We're not administering 5% dextrose, that glucose in water, which is not an isotonic solution, and not 45% normal saline, or 0.45%. That's a hypotonic solution. Only isotonic solutions here. So write it down again. Lactated ringers or normal saline. Biggest NCLEX tip. So Kaplan mentions, the nurse is caring for a client with full thickness burns covering 20% of their body. What is the priority of care after ensuring a patent airway? IV fluids. And Saunders mentions, extensive burn injury, 45% of the total body surface area. Planning for fluid resuscitation, the nurse should consider that fluid shifts to the interstitial spaces is greatest during which period of time? Between 18 and 24 hours after the injury. Yes, the key term here is before or within 24 hours of the injury. Fluid resuscitation is priority, with normal saline and lactated ringers are isotonic solutions. So please be sure to write that down. That will save a life, and it's the most tested. Now for the big signs and symptoms of major burns. These ones love to show up on exams. The key point is that in the first 24 hours, as cells burst and cellular damage occurs, the cells release potassium into the bloodstream, causing high potassium, that hyperkalemia over 5.0. So just think, potassium is priority since it pumps the heart muscles. So with high potassium, we have high pumps of the heart, leading to key terms, tall peaked T waves, on the ECG monitor. Huge NCLEX tip and a big priority, because this could lead to deadly cardiac dysrhythmias, making potassium always the number one priority. Now, some other expected findings. We see low potassium, that hyponatremia, below 135, another big NCLEX tip, so write down that key number. Sodium is lost as fluid shifts within the blood vessels and into the tissues here. So just think, where fluids flow, electrolytes go! Now, don't let the NCLEX trick you here. Potassium is the priority here, with all those peak T waves that can lead to cardiac dysrhythmias and kill your patient. So remember, focus on any potassium higher than 5.0, because that is the priority. Now lastly, elevated H&H. So we'll see a hemoglobin that is elevated, normally between 12 and 18, and hematocrit is normally between 36 and 54%. But naturally, both of these will be elevated due to the low blood fluid volume, that hypovolemia, making the remaining blood very thick and hemoconcentrated. So that's why we see an H&H that is high when the body is dry. Now, Saunders mentions severe burn injury that covers 35% of the total body surface area. The nurse is most likely to note which finding on the laboratory report. A hematocrit of 60%. Yes, that is elevated, indicating hemoconcentration. Now, for the rule of nines. For your NCLEX and your exams, you must know how to calculate the rule of nines. Over 70% of students get these questions wrong, so be sure to listen close. A big test tip here is I recommend to write out this chart at least 10 times every single day the week of your exam. It's kind of like lab values. You need to know your numbers here. Okay, now as you can see, the rule of nines is used to quickly estimate the percentage of the body affected by a burn. This is called total body surface area, and it's used to calculate the exact necessary fluid resuscitation that is needed and required level of care for the client. So for example, the head and the neck are 9% total, 4.5% for the front and 4.5% for the back, aka anterior for the front and posterior for the back. Now the arms account for 9% total. Once again, 4.5% for the front, the anterior part, and 4.5% for the back, the posterior. And the same thing for the legs, but this is 18% total. So 9% for the front and 9% for the back. Now the most interesting part here is there's only 1% for the perineum. Wait, what? 1%? Okay, yeah. One, womp, womp, womp. Okay, now a commonly missed question here. A client has a full thickness burn to all the posterior body surfaces. Using the rule of nines, calculate the percentage of total body surface area that is affected. Guys, a lot of students get these wrong, so you must know your rule of nines numbers. Okay, now looking at the chart here that we memorized, we know that only the posterior body surfaces are affected from the question. So 4.5% for the head, 18% for the entire back, 9% for the right and left arm, and 18% for the right and left leg. So the answer is 49.5%. Now most exams ask you to round to the nearest whole number. So the answer would be 50% of the body, which makes sense because the entire back or posterior of the body has been burned here. So half the body's been burned, so 50% of the body. Now the next top missed question. The client has partial thickness burns to the anterior legs and perineum. Ouch. Using the rule of nines, calculate the percentage of total body surface area affected. Okay, so anterior legs and perineum, which includes that measly little 1% for the peri area, womp womp womp, and 18% for the right and left leg, since only the anterior is affected, or the front. So the answer is 18 plus 1 is 19%. Now, once the total body surface area is calculated, then the volume needed for emergency fluid resuscitation within the first 24 hours can be calculated. using the Parkland formula. So write this down. We take 4 milliliters multiplied by the kilograms of body weight and the total body surface area percentage. Now, this is not commonly tested on the NCLEX, so I wouldn't freak out too much, but it may show up on your nursing school exams. So let's do a quick little example. Taking from our previous question, let's say the client weighed about 100 kilograms with that 19% total body surface area affected. Now we're calculating the lactated ringer fluid of resuscitation needed. So using the formula, we're taking 4 mLs times 100 kilograms, let's just say, and from the previous question, 19% total body surface area. You take those bad boys, multiply them together, and the answer is 7,600 milliliters within the first 24 hours. Now, we give the first half of fluid in the first 8 hours of the incident, so around 3,800 mLs, and the remaining fluid we deliver over the next 16 hours, another 3,800 mLs. But again, I wouldn't focus on this too much for the NCLEX. This is mostly used for your nursing exams. Now for the treatments of major burns, as mentioned before, during the emergent phase, the number one intervention in the first 24 hours, hopefully you wrote this down, we give isotonic solutions like IV lactated ringers and IV normal saline. Now, how do we know if fluid resuscitation is working or not? Well, the assessment of fluid resuscitation, big key term here, urine output 30 mLs or more. Huge NCLEX tip. Make sure to write that down. Urine output is a vital sign that indicates fluid resuscitation has been effective. So that's why we say 30 mLs per hour or less means the kidneys are in distress. Now the second key point of fluid resuscitation is blood pressure. So 90 systolic or more and a heart rate less than 120 beats per minute. This means that fluid resuscitation has been effective. So I'd recommend pausing your screen and jotting these down. These were the most tested for fluid resuscitation. So don't let the NCLEX trick you here. Electrolyte balance is not the best indicator of fluid resuscitation. It's always urine output, then BP, and then heart rate, the top 3 there. So Saunders mentions, a client undergoing fluid replacement after being burned 20% of their body about 12 hours ago. The blood pressure is pretty low, 90/50, a pulse rate of 110, and a urine output of 20 mLs over the past hour. The nurse anticipates which prescription. Okay, so look at the key terms here. The BP is definitely not looking good. We're probably going to slip into hypovolemic shock for sure. So increasing the IV lactated ringer solution is the best option. Now, once the client shows adequate urine output and urinating or diuresing over 30 mLs per hour, then we can administer enteral feedings once bell sounds return. Nutrition is always a priority, but only after fluid resuscitation. This helps the client meet caloric intake required to rebuild damaged tissues from a burn. Now, as the body heals with open wounds from major burns, infection is a huge deadly risk here. So Kaplan mentions, a patient with burns who is immunocompromised, what precautions should be taken to prevent infection? Now, the key words here are immunocompromised and prevent infection. So avoid placing fresh flowers or plants in or near the client's room. Yes, we always want to avoid crowds, fresh fruits, and all the typical stuff for clients who are immunocompromised to prevent infection. Now, during the rehabilitation phase, this happens when wounds fully heal and typically takes around 12 months or so, depending on the severity of the burns. Now, the big key point to write down is that infection is not a big risk here. As wounds have been fully healed, there's no more open sores. So don't let the NCLEX trick you here. Infection is not a big risk. 80% of students get this wrong. So pay attention to the W's here for patient education. Big NCLEX tips. First W is for water-based lotion, which helps to minimize itching and scarring to allow the skin to fully heal. The second W is to wear pressure garments. Yes, don't let the NCLEX trick you here. Wearing pressure garments are good to help minimize scarring. It also helps to keep the skin and tissues tight while promoting circulation, to be able to fully heal. And E is for exercise daily with range of motion. This helps to promote movement and prevent stiff joints, and we always encourage sunscreen and protective clothing when going out in the open sun to prevent those darn sunburns. Alright, that wraps it up. Thank you so much for watching. Don't forget to take the quiz and download the. Now for the practice questions on burns. Question 1. The nurse caring for a client with partial thickness burns expects which findings upon assessment? So pause the screen and try your best to answer this question in about 60 seconds or less. Okay, let's break it down, following the question breakdown strategy. So number 1, first look at the key terms in the question. Partial thickness burns, and the question is asking for which findings upon assessment. So the second thing is think of a few things you know about those key terms. Remember from the full video, partial thickness means second-degree burn. So painful blisters with key terms here: red, moist, shiny, fluid-filled vesicles. Basically, blisters. Okay, now let's look at the options. So option A, areas of painful redness without elevation. No, this is incorrect. It is painful and red, but partial thickness second-degree burns do have elevation with those blisters, or those fluid-filled vesicles. Now option B, areas of painful fluid-filled blisters. Yes, the key term there is fluid-filled blisters. So this is the most correct, as all the key terms are there. Now option C is incorrect. Areas of dry, painless, leathery skin. So this is not mentioning of blisters. Remember, dry, painless skin is usually that of a third-degree problem. Now option D, also incorrect. Areas of black, cherry red, or white patches. No, so this is incorrect because areas of black skin can either be third or fourth degree, but it's most likely fourth degree. Now moving on to question 2. The nurse is assessing a client with severe full-thickness burns. The client suffered burns to the front and back of the head, the right arm, and chest. Using the rule of nines, what percentage of the body is burned? So pause the screen and try your best to answer this question in about 60 seconds or less. Okay, let's break it down following the question breakdown strategy. So number 1, first look at the key terms in the question. Severe full-thickness burns to the front and back of the head, right arm, and chest. So using the rule of nines, let's break it down. So front and back of the head is 9%, basically 4.5% for both sides. The right arm is also 9%, with 4.5 accounting for both sides. And the chest is only 9%. So add 9 times 3 and we get 27%. So option A would be the most correct. All right, that wraps it up. Thank you so much for watching. Don't forget. So the pathophysiology, it's a bacterial skin infection of the deep dermis and subcutaneous tissues, typically caused by a staph infection, like Staphylococcus aureus. Now, it's normally found in a lower limb, near the tibia, for example. So Hesse mentions, swab culture for cellulitis infection. The nurse anticipates the culture will grow which causative specimen of bacteria? Staphylococcus aureus. Now for the risk factors, this includes patients with trauma, a history of diabetes, and even history of cellulitis, and history of athlete's foot, that tinea pedis, basically a fungal infection, as well as lymphedema, obesity, and even venous insufficiencies, where blood flow is limited to the lower legs. Now for signs and symptoms, just think about cellulitis. We have inflammation and infection. So it includes a fever because of the infection, as well as pain, warmth, tenderness, and swelling and erythema, or patches of redness to the affected area. If untreated, it can grow into an abscess, basically a big ball of infection, and then lead to sepsis and chronic edema. So Hesse mentions, a patient with a fever has erythema, pain, and tenderness over an area of skin, Which infection does the nurse suspect in the patient? So the key terms here are fever, erythema, and pain over the skin. So skin is a huge key term. So cellulitis is the answer. And another question, which statements regarding cellulitis are true? Select all that apply. Complications can include sepsis, yes. It can include an abscess if left undiagnosed and untreated, yes, also true. It occurs when bacteria enters the body through a break in the skin, yes. And it can spread by direct contact with open area on a person who has an infection. All are true. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love. Now for atopic dermatitis versus contact dermatitis. So starting with atopic, also called eczema. This is a condition wherein patches of the skin become inflamed, itchy, cracked, and rough. Sometimes they can also cause blisters. It is an autoimmune disease, meaning the body attacks itself, attacking the skin. And it tends to flare up periodically when exposed to allergens. Now the main cause is inherited, or basically genetics. And it's very common in infancy, but can happen at any age. Now the manifestations to write down. We see chronic inflammation of the skin, as well as erythematous rash with serous exudate. Fancy words for a red rash that might be leaking pus. Now for contact dermatitis, this is a condition that makes skin red or inflamed after contact with an allergen or irritant. Now it's very different than atopic dermatitis in that it's caused by an irritant outside the body. For example, an exposure to an allergen like poison ivy. So we see a pruritic rash within hours. There's no immune response necessarily, because it's direct exposure and an inflammatory response. Now for interventions, big NCLEX tips. So I'd write these down. We must trim nails to avoid scratching. Number 2, use lukewarm or tepid sponge baths with soap. We really want to avoid long baths that are too hot, as they may dry out skin even more. So write this down. We pat dry with towels and never rub. And apply moisturizer immediately after bathing. The goal here is to keep the skin moisturized. And lastly, we always recommend cotton clothing because it's soft to prevent itching. Never wool clothing. This is rough fabric and this could intensify itching. So again, write these down. They love to show up on Select All That Apply questions. All right, that wraps it up. Thank you so much for watching. Don't forget to take Now for shingles, also called herpes zoster. It's caused by reactivation of varicella zoster virus, which is the virus that causes chickenpox. So patients that have had chickenpox as a child are most likely to get shingles in older age. This kind of virus is an opportunistic infection, meaning that it waits till the body's defenses are weak before attacking. So the risk factors are pretty simple. Just think of a client whose defenses are down, called immunocompromised, or a compromised immune system. Say a weak immune system like clients on immunosuppressants, or clients undergoing chemotherapy, or even clients fighting off another infection like pneumonia, where the immune system is preoccupied fighting another battle. Now, other causes include poor nutrition or even too much stress and fatigue, like recovering from surgery, or even like students in nursing school or those preparing for the NCLEX. We're talking lots of stress here. Now, the HESI mentions risk factors for shingle outbreak. Select all that apply. So a client who's had the chickenpox as a child, admitted to the hospital for pneumonia, or even a client who's stressed about finances because the spouse is battling with cancer. Yes, all are risk factors. Now, in terms of signs and symptoms, we have a rash that runs horizontally along the left and right side of the torso. Now, the rash can present vascular, pustular, or even crusty, with a low-grade fever and paresthesias, that burning and numbness and tingling. And the treatment is pretty simple. We isolate the patient in a negative airflow room until vesicles are crusted over, and avoid exposure to anyone who has not had or been vaccinated against chickenpox. And lastly, we administer antiviral medications like acyclovir, as well as give analgesics for the pain. So let's play that segment now from our pharmacology master course. These guys end in cyclovir, like acyclovir and valacyclovir. Now they kind of sound like circle here, since herpes sort of look like circles. And you can remember the vir is used to treat the viruses, like certain types of herpes. So herpes genital and cold sores, and herpes zoster, which are shingles. Now the big key points here, guys, write these ones down. We take daily, and also there's no cure since it only slows the virus. And big one here, you avoid sex while lesions are present. Guys, there were like 3 HESI exit questions about that. Lastly, we drink extra fluids, and it's also effective for less frequent eruption of lesions. Big keywords right there. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. It's a very common, highly contagious skin infection affecting infants and children. So the memory trick, just think infantigo is for infant tigo. Now it's caused by a strep or a staph infection, which is really dangerous in children, as that strep infection can travel all the way down to the kidneys, causing glomerulonephritis, secondary to a streptococcus infection. Be sure to write that down. This is highly tested on the NCLEX. Because remember, the most deadly complications are typically the most tested complications. So once again, glomerulonephritis secondary to a strep infection. Now for signs and symptoms, we see itchy red sores mainly on the nose and mouth, as well as the hands and feet. Now these sores can burst and dry into honey-colored crusts. This is when the infection is the most contagious and most easily spread. Now, a more serious form of infantigo is called ecthyma, where it penetrates deeper into the skin, causing painful fluid or pus-filled sores that turn into deep ulcers. And it spreads when a child has open sores or items they've touched, such as clothing, bed linen, towels, and even toys. So for treatments, the big NCLEX tips. Be sure to write these down. They love to come up on Select All That Apply questions. So number 1 is no school or daycare to prevent the spread of the infection, especially when there are open sores. Number 2, we always wash hands before and after touching infected areas. Number 3 is separate the child's clothes and towels from other laundry, and always wash with hot water. And number 4 here is short and filed fingernails. Because of the itchy skin, we want to decrease the risk of causing more open sores. And number 5 is softly remove crust and debris from those open sores, as mentioned by Kaplan. So HESI mentions, a child has infantigo. What actions should the nurse take? Send the child home with the parents to see the HCP. And Kaplan, care for a child with infantigo. Which information does the nurse include in the teaching plan? Soften and remove crust and debris. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a... Now for pressure injuries, formerly called pressure ulcers. These result from damage to the skin or underlying tissues over a bony prominence, commonly from bedridden clients who are not turned adequately, or from a medical device due to intense or prolonged pressure, like long-term use of oxygen devices, like a nasal cannula or even an oxygen face mask. But typically bed sores are the most tested here, resulting from bony prominences, basically areas that feel bony. So the top 3 most common areas are the lower back and buttocks, including the sacrum and coccyx, the heels and the ankles, and even the hip bones, very bony areas. These 3 are the most common areas for pressure injuries, but even the shoulder area like the scapula and the elbows are high risks. Now, in terms of the causes and risk factors, just think of the patho here. The skin is breaking down from all that pressure, as well as other factors that can make the skin weak. So write this down. Bedridden clients who are immobile from either neuro issues, spinal injuries, or just intubated and sedated. Whatever the cause, being in bed for long periods of time degrades the skin. Secondly is incontinence, or having a wet bed, where clients can't keep urine in with incontinence. Now, wet skin leads to skin breakdown. Another cause is from poor nutrition, with low protein or low fluid intake. This puts the skin at higher risk for skin breakdown, since it lacks the building blocks for healthy skin. Another cause is our diabetic neuropathy, the lack of sensation with our diabetic patients, and the lack of skin perfusion due to that thick syrupy blood, so we end up with foot ulcers, which are very common. And lastly, clients with liver cirrhosis have low albumin. The lack of albumin, which is that protein that attracts fluid back into the vascular spaces, so we end up with a bunch of fluid that leads to edema, basically waterbed skin, so a high risk for skin breakdown. Now, in terms of the 6 stages for pressure injuries, make sure to focus here on the pictures. The NCLEX and exit exams love to show pictures and ask you to name the stages. So stage number 1, we have red skin that is intact and only affects the epidermis, the outermost layer of the skin. So just think only 1 layer of skin damage for stage 1. Now it's non-blanchable, meaning that it does not turn white when pressed on. It stays red. Now if it is blanchable, then it's not a pressure injury yet. Now for stage 2, the skin breaks and we have an open wound, but just affecting the top 2 layers of skin, the epidermis and the dermis. So just think 2 layers of skin damage for stage 2. The wound bed is red or pink and shiny or dry. Now for stage 3, we have full thickness skin loss, extending into the subcutaneous, that fatty tissue that kind of looks like bubble wrap. The wound may be tunneled under the edges of the wound bed, so just think 3 layers of skin damage for stage 3. Now stage 4, this one is the worst. It extends all the way down into the muscle, bone, or even tendon. So just think 4 layers of skin damage for stage 4. Now the unstageable one, huge NCLEX tip here. We have full thickness skin loss with 2 key signs to write down. Eschar, which is known as black or brown dead necrotic tissue. So just think eschar is like coal because it's black or dark brown. And the second key term is slough, described as yellow and stringy. So I'd recommend writing these 2 down. Slough is that rubbery substance looking kind of like chicken skin. So think slough is like stringy chicken skin. Take a good long look at this nasty picture here. A lot of questions ask you to identify this one. Now, since there are 2 colors that are preventing visualization of the wound bed, it's classified as unstageable. These wounds typically need to be cleaned out or debrided in order to visualize the wound bed before a stage is made. So Hesse mentions, the nurse is assessing the skin of an immobile patient. Skin covering the sacrum appears to have full thickness loss, but the wound base is covered in black eschar. How does the nurse document the finding? Unstageable pressure ulcer. Now our last one here is a deep tissue, which presents as dark purple and will sometimes come open. The fatty tissue is injured below the skin. Now it's not typically tested, but I would be familiar with this one. Now in terms of the treatments, it really depends on the cause here. So for clients who are bedridden, we must first assess the skin and document, especially within the first 24 hours of admission. If not found and documented within the first 24 hours of admission to the hospital, then the hospital assumes responsibility of the wound, even if it's not the hospital's fault and not even caused there. So a full head-to-toe skin assessment is priority. We must take a picture and document and stage any wound upon admission. Next, we must turn every 1 to 2 hours, especially clients with high risk, like those who are bedridden. So make sure to write it down. This is done every 1 to 2 hours to relieve pressure on the bony prominences. Now, Kaplan mentions, the nurse is teaching a client with a stage 1 pressure ulcer on the greater trochanter of the left hip. What should be included in the teaching? Change position every hour. Now, in terms of nutrition, protein and fluids are priority here. So fluids at least 2 to 3 liters per day. This helps to build and maintain healthy tissues. Now, how do we know if the client has adequate fluids? Well, we monitor urine output. So write this down here. Urine output 30 mLs per hour or less